wanted to give you a kind of a short overview of pathophysiology in relation to what or how Giddens has it played out in your concepts book. First thing, though, is you guys have had fluid and electrolytes, and what I'm putting in front of the screen is a copy of your pathophysiology notes from your instructor last semester. So if you want to, you can refer back to those so that you can, go back and review. So with fluid and electrolytes, I'm in Chapter 8 in your Giddens book, Concept 8. And the learning objectives, we're going to define and discuss the concept of fluid and electrolytes and look at and review the normal pathophysiological processes. And then later on, really and truly, this is a section I probably shouldn't be going over, but it's difficult to kind of grasp your mind around unless you hear it more than one time. So I wanted to do a quick overview. So we're going to look at water regulation, water distribution, talk a little bit about the role of it in the body, the electrolyte regulation, distribution, and the physiological roles of electrolytes. So if you're looking at Giddens, I've taken a lot of these pictures and things out of Giddens, so that hopefully you can look at your Giddens book and listen to what I'm saying here, and it all kind of will come together for you. So the normal physiological process with fluid and electrolytes is, first of all, we have to have a normal way to take fluids and electrolytes in. So either through IV, NG, through our thirst stimulus that tells us that we're thirsty, along with subcutaneous tissues and intraosseous or through the bone. Then we have to have absorption, which is important for oral intake of calcium and magnesium. We have aspects within our gut that allow us to absorb these electrolytes. And they're specialized absorptive things such as the intrinsic factor that we must have. Calcium is absorbed in the duodenum and magnesium is absorbed in the terminal section of the ileum. So that has to be in place to have adequate intake of fluid and electrolytes. And then we have to have a good distribution system. So filtration distributes extracellular fluid between the two compartments. So we have where things are being distributed back and forth between the vascular and the intracellular, and this relates to osmosis, diffusion, things like that. We also have to have organ structures that are working correctly, such as our kidneys and our liver, in order for this distribution to occur. We can also have, with distribution, what we call osmosis, which is where distribution of water between extracellular fluid and intracellular fluid due to osmotic forces. Okay, so and electrolyte imbalances and things like that. So we have to have these aspects. So when you look in your concepts book, it talks about the concepts and the categories. We have fluid and electrolyte categories, and this is broken down into fluids and electrolytes. So with fluids, we can have extracellular deficiencies or excesses, or we can have an optimal level. We can also have osmolality issues, and this is where we're going to be getting into our sodium levels, hyponatremia and hypernatremia, where we can have a deficiency or an excess. And then we can have our electrolytes, which is we can have deficiency or excess regarded with our electrolytes as well. So common themes are optimal, deficiency, or excess, too much, too little, or just right when we're dealing with fluids and electrolytes. So for optimal balance, we want to have an intake and absorption of fluid and electrolytes, so that we want to have a match. Whatever goes in, comes out. Okay, and as nurses, we need to do a good job of trying to keep up with intake and output, and really look at things and consider what's going on with the patient. So also with optimal balance, we have volume and osmolality, electrolyte concentrations, and all these things need to be within normal limits. And so we're going to talk about, as we get through into the class portion of it, we'll talk about the different levels and the lab values that you need to know and put up here in your memory bank. So with extracellular volume imbalances, so we can have, when we talk about this, normal extracellular fluid is isotonic, which means it's a sodium-containing fluid, and it's what what keeps things in balance. Okay. Remember, sodium is necessary to keep water in the extracellular compartments. If we don't have sodium, then we start losing that water. So it has to do with how we concentrate our urine and things like that. So extracellular volume deficiencies, we can have too little sodium-containing isotonic fluid in the extracellular. So we This is usually caused from a lack of access to sodium and water. Okay, they can't get enough of this, so they may end up being dehydrated and have an isotonic fluid loss. Also, we can have increased output not balanced by increased intake of sodium and water. So, if somebody's taking in plenty of fluids, but they're having excessive amount of vomiting, acute or chronic diarrhea or laxative use, maybe a hemorrhage or a burn, okay, they're going to start losing too much fluid. People that overuse diuretics, and some people you're going to find that have certain types of disease processes such as Addison's disease and adrenal insufficiencies will have more output. They will not be able to maintain that balance. We can also have a rapid shift from extracellular volume into the third space. So if somebody has an acute intestinal obstruction, then ascites can occur and develop rapidly. And if you look with this particular person, the ascites is caused from a liver blockage, where we no longer have that circulation and that ability to distribute the fluid and filter the fluid like we should. Extracellular volume excess can occur because when we have a decreased output, not balanced by a decreased intake of sodium or water. So individuals that maybe they're drinking plenty, okay, but they have acute kidney injury or acute glomerular nephritis, which means they've had lots of kidney infections, or they're in end-stage renal disease, we'll see a diminished output, which means they're going to hold on to things that their body doesn't really need, chemicals and things that can cause harm. Aldosterone excess sometimes can occur, such as with cirrhosis, chronic heart failure, and then primary hyperaldosteronism. And then we can also have high levels of glucocorticosteroids, such as individuals that have Cushing's disease or people that are on daily steroid treatments. They will have a lot of excess fluid. Their output will be significantly diminished compared to their intake. Extracellular volume excess, also we can have too much sodium containing isotonic fluid. If we have too much salt, we're not going to put out the urine and the excess waste like we typically would. So output is less than excessive or too rapid of sodium and water. So if we have somebody, we can have excess because we get too much of something. So if we have an excess of IV infusion of sodium containing isotonic solution, 0.9% sodium chloride or ringers, or a high oral intake of salty foods such as you sit and eat a whole bag of sunflower seeds. Okay, this can cause us to have a diminished output. Osmolality imbalances can occur. So with osmolality, we can have deficiency or excess. And so dehydration is typically equals the reduced extracellular volume and hypernatremia. Okay? So we can have changes in the degree of concentration of the body fluids. There's two types of osmolality issues. We can have hypernatremia. So this means we have an increased serum sodium concentration. All right? Or we can have hyponatremia, decreased serum sodium concentration. So it may occur alone or with extracellular volume imbalances. Sometimes hypernatremia, it could mean that the person's taking in too much sodium, or it could mean that they've lost too much fluid. Okay, and we'll talk about this more in the classroom setting when we get into some of the specific disease, more specifics about this. Hyponatremia can occur because of too much fluid. Okay, so either they don't have enough sodium in their system, or they have too much fluid, which is over diluting that sodium. Osmolality balance can occur, and we're going to talk about this a little bit more. Hypernatremia, so body fluids are concentrated, so the osmolality is too high. So with this, we're going to see a blood level of sodium of greater than 145 milliequivalents per liter. Normal output, but deficient intake of water. Okay, so if somebody has good output, but they're not taking in enough water, then their sodium levels can inadvertently be high. Also, we can see this with no access to water or the inability to respond or communicate when somebody's thirsty. Maybe they have aphasia or coma, or they're an infant. And you're going to see this with differences with children, as they can't communicate this effectively. Also, we may see hypernatremia with tube feeding without any additional water intake. So sometimes you'll hear physicians that will write orders for individuals to have free water. Hypernatremia can occur, and I kind of already explained this just a little bit ago, when body fluids are concentrated, so the osmolality is too high. So we could have an increased output not balanced by the increased intake of water. So vomiting or diarrhea with replacement of sodium but not enough water. So if we give them back their sodium but we don't give them enough fluid. And then also you're going to learn in future classes about diabetes insipidus. This is where we have a lack of antidiuretic hormone. Okay. So moving along. Also we can see hyponatremia with body fluids become very dilute. Okay, meaning that the osmolality is too low. So blood levels of sodium here would be less than 135 milliequivalents per liter. Output is less than excessive or too rapid of intake of water. So we have IV 5% dextrose in water infusion with an excessive rate or amount. We could end up with hyponatremia. Also rapid oral ingestion of water, where somebody drinks a gallon of water, can lead to hyponatremia. Overuse of tap water enemas, this is why it's real important that we control this very carefully, or massive replacement of water without sodium during vomiting and diarrhea. So it's a balance that we have to really keep a close eye on. We can also have hyponatremia because body fluids are dilute or osmolality is too low. So we have a decreased output not balanced by decreased intake of water. So, for example, some people have syndrome of inappropriate ADH, which we have excessive diuretic hormone. So they're going to put out large amounts of very dilute urine, and they're going to have hyponatremia because their body fluids are way too excessively diluted. Altered fluid and electrolyte distribution, you can also have a shift of vascular fluid into the interstitial space. And so we can have altered filtration, which can lead to edema, inflammation, and vasodilation. We can have hypoalbuminemia and decreased blood colloid osmotic pressure. So you'll see a shift of the vascular fluid into the interstitial spaces, and sometimes this will lead to that swelling that we're going to see in our patients. We can also see a rapid extracellular fluid shift into the third space, and we talked about this a little bit earlier. Peritoneal cavity and the intestinal lumen, we can end up with ascites. And this may cause extracellular volume deficit, okay, because the fluid is caught. It's in a space it can't get out, and it may occur gradually. We can also have altered fluid and electrolyte distribution from extracellular fluid into the electrolyte pool. So calcium, potassium, magnesium, we could have low concentrations in the extracellular fluid and high concentrations in the cells and bones. And so what this is going to cause is signs and symptoms by changing the ratio of electrolytes inside and outside of the cell. So when we get more specific into the different types of electrolyte imbalances, you're going to see things where we have muscle contraction, problems with hyperactivity of our reflexes. Electrolytes can cause lots of problems with EKGs and things as well. The consequences of electrolyte and fluid and electrolyte imbalances is we can have extracellular volume and electrolyte concentrations interfere with perfusion and oxygenation, so we can have issues there with our patients. Osmolality imbalances can affect the cerebral function, so when we start to take a look at some of these disease processes, you're going to see where confusion, fatigue, irritability become some of the symptoms that we're going to see. And then electrolyte imbalances can impair neuromuscular function. So again, you're going to start seeing where people have tics and irregularities with walking and with their reflexes and things when we talk a little more about this in the class. Again, this section was just meant to be a review for hopefully to guide you through the Giddens chapter and help you refresh your memory on some of the things that can occur. Thanks and have a good day.